The FlightBridgeED Air and Surface Transport Symposium is back, May 18th through 20th of 2020. Join us in Murfreesboro, Tennessee for our third installment of one of the best EMS conferences in the nation. Guys, I gotta tell you, get to the FlightBridgeED.com website, click on the Fast 20 button, check out all of the pre-conference offerings. We have more than ever this year. Our speaker lineup is going to be incredible. If you've been to Fast 18, to Fast 19, you do not want to miss Fast 20. Go to FlightBridgeED.com, click on Fast 20, get your tickets now. We'll see you in Murfreesboro.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today we're going to do part 3 of our congenital heart defects. We're going to go through tricuspid atresia and a hypoplastic left heart. And there's actually a lot of similarities between these two. Tricuspid atresia, the first one we're going to talk about, is a problem with an incomplete or non-existent tricuspid valve. Essentially, there's either a piece of tissue or a plate, we'll say, in place of that tricuspid valve that does not allow blood to flow into the right ventricle, and that causes that right ventricle to be hypoplastic or underdeveloped. These kids will also often have an associated atrial septal or ventral septal defect. Just like we've talked about with previous podcasts on this subject, this is a cyanotic lesion. This means that PDA patency is a must. Prostaglandin therapy is going to be initiated and started immediately. Dose of 0.03 to 0.1 mics per kilo per minute is a very common starting dose range. Just like we have talked about, if there's no atrial septal defect, they will definitely cause one. They do that again by either doing this at the bedside or in an interventional lab, but they're going to enlarge and stent open that foraminal valve. Remember, the foraminal valve is the hole between the right and left atrium that closes once the baby starts breathing oxygen and the right side of the heart becomes the low pressure side, left side becomes the high pressure side. That hole closes. So the main part of this surgery is going to be the first week of life, and that is called a Blalock-Tasic shunt. And essentially what they're going to do is make a shunt or a connection from the right subclavian to the pulmonary artery. That is essential. At that point, we're going to see 2 more surgeries, and this is where we get very, very much like a hypoplastic left heart, and that is surgery number 2 happens between that 4 and 6 month mark. And ironically, it's the same exact procedure that was invented for the hypoplastic left heart, and that is called the Glenn procedure. The Glenn procedure essentially means that they're going to take the superior vena cava off of that right atrium, and they're going to actually then connect it to the pulmonary artery. So again, that happens at the 4 to 6 month mark. The next procedure is going to be at the 2 to 3 year old mark. And that 2 to 3 year old mark, that surgery is exactly the same surgery that we're going to see in the hypoplastic left heart. That's called the Fontan procedure. And the Fontan procedure is where they dissect off the inferior vena cava off of the lower part of that right atrium. And they obviously have to make a homograft, and they have to graft that, and they're going to connect that also to the pulmonary artery. Now, remember, the right side of the heart is completely hypoplastic, right? We have a non-existent tricuspid valve. We have an underdeveloped or hypoplastic right ventricle. So essentially what you're seeing is that they're redoing the plumbing, and they're bypassing that area of the heart. So as you can see, this surgery, or these 3 surgeries, are over a long period of time. There's obviously going to have to be cardiac follow-up continuously. These kids are going to be, very hypoxic. They're going to have lower SpO2s. But this is tricuspid atresia. It's not one that you hear a lot about, but this is very common when you look at the neonatal congenital defect population. So let's go to our number 2, and that is going to be to segue to a hypoplastic left heart. When you look at hypoplastic left hearts, and we looked back 10 to 15 years ago, the survival rate for hypoplastic left hearts were much worse than they are now. So the key here, hypoplastic left heart, means that you have a hypoplastic or non-existent, very tiny left ventricle. The other problem with a hypoplastic left heart is that you have a very small, incomplete aorta. So the aorta is almost like a spaghetti noodle. It is very, very tiny. It is also hypoplastic. And so you have two main problems there. This is also considered a cyanotic lesion. So that means ductal dependency is key. The thing with a hypoplastic left heart that we know is that the SpO2s on these kids could be as low as 70%. And there are some cases where we know that oxygenation, even at room air 21%, is too much. And so there are some cases where they have to gas mix with nitrogen, and they're going to reduce the FiO2 down below 21%, maybe to 19, 20%. Prostaglandin therapy will be initiated, as we've talked about, with every one of these congenital defects that are cyanotic in nature. And the key is to look at this from a 3-step process. So as we talked about with the tricuspid atresia, we're going to see 2 of the same surgeries. But what kicks this whole thing off is what's called the Norwood procedure. And the Norwood procedure was actually invented by Dr. Norwood. It was invented about 25 years ago. And when we look back 25 years, this was the only surgery that they did on a hypoplastic left heart. So there's been progressive surgeries, the Glenn and the Fontan procedure, that have been invented and implemented since then, that have really improved and increased the survival of these neonates. So what is the Norwood procedure? When does it happen? It happens again at the first week of life. This is where they're going to connect the pulmonary artery to the aorta. They're going to make one large graft. Again, that's called a homograft. And that's one large graft because, again, remember, that aorta is very small. It is also hypoplastic, and it is not appropriate. The second procedure is going to happen at that 4 to 6 month mark, just like we saw with tricuspid atresia. That is called the Glenn procedure. Again, the Glenn procedure is where they're going to take the superior vena cava off of the right atrium, and they're going to make a connection to the pulmonary artery. That is at 4 to 6 months. And then the last procedure is at between 2 and 4 years old. This is where, again, they're going to do the Fontan procedure. They're going to take off the inferior vena cava from the bottom of that right atrium. They're going to make a connection, a graft, and connect that to the bottom of the pulmonary artery. And now you have essentially one ventricle heart. Your right side is going to be the primary area where everything is happening, all the magic is happening. These kids actually are doing very, very well nowadays. I have met a few hypoplastic left heart kids, have met a couple people with family members that have children that have had hypoplastic left hearts, and they have done very, very well. They're maybe not as exertional as other kids. They do appear to still be a little bit hypoxic, but overall, it seems like these kids are doing very, very well. The other thing we have to understand with hypoplastic left hearts, just like we talked about in part 1 when we looked at the coarctation, there are cases, and one of the cases that I do know about is somebody I met in one of our classes where a hypoplastic left heart was not diagnosed prior to the baby being born. Baby actually went home. Parents, physicians had no clue that this baby had a hypoplastic left heart. And what actually caused the diagnosis was day 2, day 3, the PDA closed. That PDA was actually allowing enough of a second outflow tract. Obviously, you have the aorta. The PDA is allowing for that second outflow tract to where there was not an overload situation. But once that closed, obviously, we had cardiorespiratory collapse. Baby was transported. The diagnosis was made, and then those surgeries were implemented, and that child is doing very well today. So hopefully these Congenital defects, again, remember cyanotic versus acyanotic. We've really focused on the cyanotic lesions of prostaglandin therapy. Remember, apnea is a primary complication, but it does not mean we have to intubate every child. But hopefully these have helped if you're studying for the FPC, the CCP-C, the CFRN, CTRN, or you're looking at the CNPT. All of these are going to be focused congenital defects you're going to have to know and understand. So if you have any questions, please email me as always at eric.bauer@FlightBridgeED.com, and I will talk to you soon.
This has been a production of the FlightBridgeED podcast, leading the way in pre-hospital critical care and emergency medicine education.